Chapter 18 Mixed Methods Research in Public Health from Theory to Practice. Krishnamurthy J.N.S. Satyanarayana Ramanik Manoj Kumar. Fatty Aaron Carr Swarup N. Tejaswini Bedi Vinod Ramani. Abstract. Mixed methods study design is increasingly adopted in recent times by the public health researchers. The two critical components of mixed methods, i.e., quantitative and qualitative approaches, are often discussed by domain experts in isolation, resulting in lack of practical application of these methods. The current chapter aims to address these gaps through blending theoretical knowledge in this domain with the practical experience of the authors. The chapter sheds light on scope, definitions, and practical considerations while planning, implementing, analyzing, and disseminating mixed methods research findings for programs and policy. The mixed methods research draws upon the strengths of both qualitative and quantitative approaches. The methodology leverages effective engagement of patient and community for identifying health priorities. However, the designing of mixed methods research requires unique methodological skill sets. The key challenge is to build a collaborative and cross-disciplinary team. When the perspectives of subjects are weaved into the research findings, the chances of engaging the community, health providers, systems authorities, and policy makers are enhanced significantly. This facilitates effective implementation of programs and optimizes health outcomes. Key words: mixed methods research, public health, health systems, community perspectives, quantitative research, qualitative research. Assess need. Mixed methods study design is increasingly adopted in recent times by the public health researchers and programmers for finding solutions to the problems on the field. Public health discipline is tasked with determining the causes and solutions to complex challenges related to population health, such as access, quality, coverage, and inequity in health services and interventions. Once solutions are identified, they must be implemented effectively and efficiently to achieve the best possible outcomes at a population level. Then, these effective interventions need to be scaled up across geographies and should be sustained by the health systems. These three critical processes, i.e., design, implementation, and scale up, vary in complexity and sophistication depending on the nature of the problem. Program science, implementation science, and implementation research methods are increasingly adopted to solve these challenges. These methods are critically reviewed and refined from time to time to suit the need. What is constant in all these approaches is the use of mixed methods at different stages of program design and implementation. The current chapter will focus on application of mixed methods approaches in a public health setting. The chapter has high relevance to medical education and research community for two reasons. One, often the two mixed methods components, quantitative and qualitative, are discussed by domain experts in isolation and not in an integrated manner. This robs opportunities for trainees to internalize an integrated and practical application of the approach to the audience is often trained to lean toward one or the other but fail to find the rich connection and complementary roles of the two. Traditionally, the academic or the research community focuses on research and program evaluation, while the government, civil society, and NGOs focus on implementation. The academicians, though not fully aware of the field realities and complexities, are expected to find answers to the issues. The program implementers, managers, and frontline workers who are on the field are expected to solve field-level issues but are not equipped with scientific methods or skills to do so. In this backdrop, program science is assuming importance, and program scientists who are equipped with skills and methods of both are the need of the hour. The current chapter is written by a team of experts who are well versed with program science and implementation research settings in low and middle income countries across a range of public health programs, i.e., HIV, maternal and child health, adolescent health, non-communicable diseases, and primary health care. While the chapter briefly outlines the theoretical aspects of mixed methods design, the main effort is to shed light on practical applications right through the planning, data collection and analysis. The chapter blends the theory with practical case studies that describe how the methodology was adopted in public health and how the data informed programs and policy. Brief, address needs of teaching faculty, doctoral, and postdoctoral scholars interested in applying mixed methods research in public health. Importance of mixed methods research and its relevance to solving complex public health challenges. How to design, implement mixed methods, analyze, and disseminate results to influence programs and policy. Case studies and practical application of mixed methods in the context of two national health programs, maternal and child health and non-communicable diseases. Mixed methods research in public health from theory to practice 219. CO and 3x3UARIZE. Two scenarios provided below provide food for thought for visualizing the public health context where mixed methods research is relevant. Case scenario 1. An high priority district in India continues to be affected by poor maternal and neonatal outcomes as a result of high rates of home deliveries in one of its blocks. Despite many health systems measures such as increasing delivery points, training of staff nurses and midwives, the situation hasn't changed. On further examination, several health behaviors of the population such as antenatal checkups, immunization rates are not optimal on account of local social and cultural norms, beliefs and practices of particular population living in the block. Questions for self-reflections. What is the best way to explore and understand the practices and local norms in the community? How does this data inform local communication strategies? Do these community-based interventions complement health systems-based interventions for optimizing district-level performance? Case scenario 2. Growing burden of non-communicable diseases in the country needs strengthening of primary health care systems so as to plan prevention, health promotion, treatment and care in a comprehensive way for the whole population. However, the medical officer of the primary health center does not have data and the information of the population. Questions for self-reflections. What is the size of his population that already has one of the NCDs? How many are vulnerable for developing an NCD in future as they have one or more of the risk factors? And finally, where are they accessing care already? Should the PHC plan for it or not? Will population access care from PHC? And what are possible health-seeking behaviors and patterns? Describe what is mixed methods research. The following explanations by experts and standard definitions give a comprehensive understanding of the term MMR for the reader. Mixed methods research is a systematic integration of quantitative and qualitative methods in a single study for purposes of obtaining a fuller picture and deeper understanding of a phenomenon. Mixed methods can be integrated in such a way that qualitative and quantitative methods retain their original structures and procedures. Alternatively, these two methods can be adapted, altered, or synthesized to fit the research and cost situations of the study. In general, mixed methods research represents research that involves collecting, analyzing, and interpreting quantitative and qualitative data in a single study or in a series of studies that investigate the same underlying phenomenon. Mixed methods is a term that is usually used to designate combining qualitative and quantitative research methods in the same research project. Few experts have preferred the term multi-method research to indicate that different styles of research may be combined in the same research project. These need not be restricted to quantitative and qualitative, but may include, for example, qualitative participant observation with qualitative in-depth interviewing. Alternatively, it could include quantitative survey research with quantitative experimental research, and it may also include quantitative with qualitative styles. Why is mixed methods research important? Mixed methods research has many benefits in addressing complex public health challenges. In addition to gaining benefits from the inherent strengths of the two methods, combining them can address the limitations that are inherent in each method. By mixed methods research, essentially, we achieve 5 key things. 1. Triangulation that seeks convergence, corroboration, correspondence of results from different methods. X. Using both quantitative survey data and the qualitative in-depth interviews to validate the underlying phenomenon or trait for a particular research question. 2. Complementarity that seeks elaboration, enhancement, illustration, clarification of the results from one method with the results from the other method. In other words, it refers how well two methods fit together and meet each other's needs. X. Elaborating the quantitative results by asking how and why questions through a qualitative study. 3. Development that seeks to use the results from one method to help develop or inform the other method, especially during sampling, implementation, and measurement decisions. X. Developing quantitative survey tools by analyzing the themes emerged in a formative research which uses qualitative techniques. 4. Initiation that seeks the discovery of paradox and contradiction, new perspectives of frameworks, the recasting of questions or results from one method with questions or results from the other method, and the last but not the least. X. Revising an interview guide for a qualitative study by carefully examining the survey results. 5. Expansion that seeks to extend the breadth and range of inquiry by using different methods for different inquiry components. X. Asking follow-up questions in either of the methods. How is mixed method research carried out? Mixing the method should be need-based. The research design needs to be explicit about the intentional use of both quantitative and qualitative methods and how the combined strengths can answer the proposed research questions. Also, the selection of methods should be informed by the nature of the problem one is studying. The rationale for using mixed methods needs to be elaborated in its design statement. For example, one data resource may not be enough. Initial results need further explanations, or a second method is needed to enhance the primary method. Mixing may happen at different points of interface. Mixing or triangulation is the key in any MMR, and knowing its purpose, sequence, and the stages in which the integration or point of interface between the qualitative and quantitative methods would occur is very essential. Morse and Niehaus identified two possible points of integration: 1. Result point of integration, and 2. Analytical point of integration. They further noted in the process of writing down the results of any first component, the result of the second component is added and integrated with the result point integration. Whereas in the analytical point of integration, a first analytical stage of a qualitative component is followed by a second analytical stage in which the topics identified in the first analytical stage are quantified. Chadley and Tashikori 2009 identify four major stages of integration. 1. Conceptualization stage. 2. Methodological or data collection stage. 3. Analytical or data analysis stage. And 4. Inferential and writing stage. Despite these classifications, the decision on the sequencing and stages of point of integration could be taken based on the typology of MMR adopted. Also, as stated by O'Cathanin et al. About the quality of mixed method studies, it is important to report the type of integration, how it occurred in the context of the team working, and who was involved in it, etc. in its study design. The data collection could be together or at two different points in time. The timing of data collection is dependent on the type of mixed method design. Four patterns are identified. 1. A parallel data collection may take place in the convergent parallel design. 2. The quantitative data collection and analysis will be carried out first, and then the qualitative data collection and analysis will be conducted in explanatory, sequential, and transformative design. 3. Qualitative data collection and analysis will be carried out first, and then the quantitative data collection and analysis will be carried out in both exploratory sequential design and multiphase design. 4. The collection and analysis of the second data set may occur before, during, and or after the first data collection in embedded design. Collaborations between quantitative and qualitative researchers. Quantitative is mainly a deductive method and ideal for measuring the pervasiveness of known phenomena and central patterns of association, including inferences of causality. Whereas the qualitative is an inductive method which allows for identification of previously unknown process, explanations of why and how phenomena occur, the conceptual thinking and specific research skills required for data collection, analysis, and interpretation of findings in the two methods are different. Data analysis and reporting considerations. The traditional approach to data analysis includes using statistical techniques for analyzing survey data and thematic analysis for interview data. Integrative strategy is another approach wherein qualitative data is quantized or quantitative data is qualitized. While reporting the outcomes of MMR, it is arduous to transparently delineate the level of data integration, which in turn results in the study design being distorted. Meta-inference conceptually refers to the intersection of qualitative and quantitative strands, which needs to be precisely specified. Researchers utilizing such designs should thus be mindful of the conflicting results and the challenges in interpreting them. In general, finding an expert well versed with the nitty gritty of both methods is quite challenging, and it demands a multidisciplinary team to conduct high quality mixed method research. Ethical considerations. Ethical considerations are an integral part of any MMR. In general, the ethical principles followed in MMR are common to other mono-method research, for example, making sure of no harm to participants, use of honest reporting, maintaining data quality measures, etc. However, the use of new and innovative ways in design and different ways to approach data in MMR insists on the importance of more rigorous ethical considerations. Path and Ali argue to intensify the ethical consideration in MMR, considering its design, which differs from mono research in terms of number of data collection and integration points, use of intensive data collection techniques, and participant expectations. Similarly, Hess and Biber suggest to make sure of the validity and data quality at different stages, framing of design, methodological choice, sampling procedure, and the researcher's responsibilities towards participants. Collins et al. Highlights transparency as an imperative aspect in MMR. Case studies and practical applications. Case study 1: maternal, neonatal, and child health. Background and problem. Despite having the policy to provide kangaroo mother care to babies with low birth weight of less than 25 OGMS, the estimated coverage of KMC globally was less than 5%. KMC is defined as prolonged skin-to-skin contact of the baby with the mother or other caregiver for as long as possible during day and night, and exclusive breastfeeding or breast milk feeding. A 2016 Cochrane review shows that KMC can reduce neonatal deaths substantially by around 40% at the time of discharge from the hospital. Between 2016 and 2019, who supported by Bill and Melinda Gates Foundation, undertook implementation research in Ethiopia and India to improve coverage of kangaroo mother care. MMR design and methods. Implementation research is a useful iterative process that assesses or evaluates implementation strategies to understand what is working or not, and also how and why it is going right or wrong. World Health Organization. The project adopted a mixed method approach where the qualitative study tried to understand the why and how practices affect the uptake of KMC in health facilities and communities, and to identify potential solutions that can inform program design in improving coverage of KMC. Multiple in-depth interviews and focus group discussions were carried out with the stakeholders such as the health officials at the state and the district, medical officers, staff nurses, frontline health workers, mothers, fathers, and grandmothers of infants. The quantitative study was designed to estimate levels of existing practices affecting KMC, measure levels and trends of KMC practice in the hospital and at home, and evaluate the intervention's influence in improving coverage of KMC to 8 hours or more. This case study is from Koppal, a high priority district in Karnataka, which was one of the study's 7 sites across India and Ethiopia. Results and implications. The qualitative studies informed that mothers were happy to learn and practice KMC but lacked clear message and support. Pediatricians perceived KMC as the skin-to-skin contact initiated soon after the delivery. It was also perceived as something that is known, old practice, and easy to do, and not as an effective neonatal care intervention. Staff nurses said that mothers were unclean and hence were not permitted to hold their low birth weight babies for fear of causing infections. Frontline workers shared challenges for continuing KMC at home because of beliefs like body heat not good for babies, body heat is not good for baby, lack of support or privacy at home. and over-reliance on prelactal feeds. The project conducted continuing medical nursing education for specialists and nurses. Regular visits by mentors to the project sites to update doctors and handhold nurses were planned. Customized educational materials were printed for hospitals and FLWs. Training of FLWs included sessions on real-life problems and possible solutions. Counselors in hospitals were trained to motivate mothers on KMC. The qualitative evidence in the formative stages of the project helped to refine and finalize the messages, target groups for advocacy, intervention tools and methods. The quantitative data helped to monitor KMC uptake and practice in communities and hospitals and gave crucial information to review and improve programs. The pilot model that started in few villages and health facilities was scaled up across the district. The government officials were engaged through the project planning and reviews. During the final year, the district-wide project was evaluated to estimate the coverage. 87% of babies were initiated on KMC at the health facility, and 53% practiced effective KMC at the facility, and 36% practiced effective KMC at home after 7 days post-discharge. From as low as less than 5%, effective KMC went up to 53% in hospitals in a matter of 2 years, which revealed many important lessons to the policy and program managers. The lessons learned and challenges were discussed with government officers, and several best practices were integrated into the state action plans. Case study 2: non-communicable diseases. Background and problem: the probability of an Indian in the age group of 30-70 years dying at present from one of the 4 NCDs i.e. cardiovascular diseases, diabetes, cancer, and chronic respiratory disease is 26%. India has been called the diabetes capital of the world, and it is estimated that 77 million Indians have the disease, and every fifth diabetic in the world is an Indian. It is projected to increase to 101 million by 2030 and 134 million by 2045. Evidence shows that the burden of NCDs and the prevalence of related risk factors are relatively higher in urban areas of India, and the prevalence is on the rise among the poor, making them particularly vulnerable to catastrophic health expenditure in addition to lifelong morbidity and increased mortality. Gaps exist at multiple levels which hinder effective implementation of services for NCDs. Although tangible efforts have been made by the national and state government on NCD services, progress towards integration of care, especially at primary care level, has remained limited. MMR design and methods: we used a mixed methods implementation research design to assess and address the gaps in an urban primary health center catchment area covering around 58,000 populations in Mysore city in Karnataka, India. We conducted a population-wide screening to detect prevalence of hypertension and diabetes in UPHC catchment area. A representative sample survey was also conducted to detect prevalence of risk factors in the population, understand out-of-pocket expenses, and treatment adherence. Facility audits were undertaken to assess readiness to provide NCD care. We also conducted qualitative research to understand client experiences and perceptions on NCD care management and lifestyle changes. Results and implications: around 35,000 adults over 18 years were screened, of which about 12% and 19% had high blood sugar and high blood pressure respectively. 11% reported tobacco consumption, 6% high alcohol consumption, 40% inadequate physical activity, and 81% inappropriate diet consumption. The facility audits revealed that public facilities lack diagnostics and specialist services, due to which most sought care in private facilities despite having to pay high out-of-pocket expenses. Qualitative studies revealed fear of side effects of mediations, myths and misconceptions that affected treatment adherence and lifestyle modification. It was found that majority of patients were not meeting treatment goals despite visits to healthcare facilities. Many challenges were encountered within the community, especially in relation to customized outreach, patient mobilization, and communication, drug adherence, ensuring individualized patient care, counseling, and lifestyle management, empowering patients, families, and enabling frontline workers to support and address healthcare needs of patients. Families were major hurdles towards the continuum of care objective. Based on the evidence generated by the MMR Urban Health Systems based implementation model was developed and is currently being implemented to address the gaps identified. This was one among the very few examples in the country where a comprehensive program for NCD was developed to address the entire care continuum in an integrated manner. The model is also informing thought process of how to strengthen comprehensive primary health care in India. Summarize, mixed methods research draws upon the strengths of both qualitative and quantitative approaches for investigating the complex processes and systems in public health research. This method is the pertinent approach where diverse insights foster the investigation of complex research questions. The lived experiences of individuals are captured in the NMR, which enables providing a patient or community perspective to the quantitative results of the study. This methodology leverages effective engagement of patient community for identifying their priorities and improving the respective outcomes. This design requires methodological skill sets for not just implementing best practices across the multiple methods, but also in articulating the quantitative and qualitative domains. This combination of skill sets enables generating different types of data and integrating them. The challenge is to build a collaborative and cross-disciplinary team for executing the complex mixed methods design and effectively manage the epistemological challenges. When the perspectives of subjects are weaved into the research findings, the chances of engaging community health providers, system authorities, and policy makers are enhanced, which is critical for effective implementation and optimizing health outcomes. The implications of such findings are progressive when compared with findings based solely on statistical data. Evaluate what relevance do you see for mixed methods research in your context? Can you visualize a public health program that you are associated with? What are the different types of integrating quantitative and qualitative approaches in AMMR? When do you begin with quantitative and qualitative and why? What are some practical considerations when you are analyzing and reporting MMR data? What are the key obstacles to effectively conducting MMR? What are some steps you can visualize in your setting to overcome them?